people here. It's a pleasure to welcome you all in this session on the Pain Talks. We have our own, the Pain Talk is pretty much a brainchild of Dr. Sadiq, who's our honored guest speaker today here. Can everybody hear me?
Yes, Amit, I can
Yes,
hear
looks
you.
like you hear me, right? Yeah, all right. So we have Dr. Sadiq here talking about how to pass exams of almost all sorts of ultrasound guided pain interventions, namely the comprehensive interventional pain sonologist exam and the American Society of Regional Anesthesia's pain exam too. Dr. Sadiq, I mean, although it's like a short bio, but I don't think it's a short, it's pretty much. Dr. Sadiq is my colleague and he's a consultant pain physician in Cleveland Clinic, Abu Dhabi. He's completed his training in anesthesia and pain medicine from UK. He's completed his FRCA and FFPMRC examinations was awarded to these fellowships by Royal College of Anesthetists, United Kingdom. He went on to complete his pain fellowship at University Toronto after completing his advanced pain training in Nottingham. So he's double certified. He's almost 2 years of training, which is pretty uncommon around the world. He has passed, namely, almost every exam, SIPS, FIP, Fellow of Pain Medicine in US. He's completed both WIP exams, and he's not even just, passed the exams. He's one of the examiners there, and he's performed very well there. So he was even awarded the top positions among the examiners. He's a clinician and educator. He has taught on multiple national and international courses. As I said, he's so much interested in pain teaching that he's almost dedicates every weekend of his running these webinars of pain talks, where we have almost professors and teachers and clinicians from almost every part of the world sharing their experiences and their knowledge about the pain. Dr. Sadiq has co-founded Leicester Pain School. He's a program director there. He's also co-founded Gulf Pain School. He's in the scientific committee, and he's the chair of Pro Academy of UAE chapter. Again, so much so, he has also written book chapters and also published multiple papers. His special area of interest are simulation in medical education, virtual reality in pain management and education, major joint denervations, peripheral neuromodulation, regenerative therapies, cryotherapies, and innovations in the field of pain management. Dr. Sadiq, it's really nice to moderate the session, and thank you for making me a moderator here. Guys, a small reminder, housekeepings, please keep your mics muted always. Stick around and make sure your mics are muted. Questions can be, you can put up questions in the chat section, and we will take them after the session, after the lecture. Dr. Sadiq, the stage is all yours.
Thank you very much, Amit. So can you see my screen, Amit?
Yes, I can see your screen.
Okay, great. So guys, what we're going to do, I'm just going to quickly run through the Pain Talks. People who are new to this platform, I wanted to tell you guys what Pain Talks is. So this is a very quick promo video of Pain Talks. Right, so that was basically a quick intro video of Pain Talks. The actually concept came from TED Talks. You must have heard TED Talks, where you have a lot of influential speakers who would come and talk on various topics. So I thought, okay, why can't we do something like that in the world of pain medicine? And that's why we started Pain Talks. So few housekeeping rules, as Amit said, please mute yourself. Put the questions in the chat box. I am recording today's session, which will go on the YouTube channel of the Pain Talks. So, and we do have a Facebook channel as well. So do like us on the Facebook, and you can subscribe to the Pain Talks YouTube channel. Now, why we started Pain Talks Education? We thought, you know what, as I said, TED Talks is a good platform where you hear a lot of great speakers. We thought, okay, we can get quite a lot of great speakers on Pain Talks, and we have done that. We have managed to get fantastic speakers talking about various clinical topics, educational resources. Last weekend, we had Professor Miles Day talking about how to prepare for interventional pain management exams, like fellow interventional pain practice exams. So he's given a fantastic talk on what educational resources you can use and how could you pass the exam. Also, what we do during this session, we give you information about various events and conferences taking place in the field of pain medicine. We tell you about the examinations in pain medicine. So we have a webinar lined up for passing the European Diploma Pain Medicine exam that will be coming soon. And we will give you the resources, what examination resources, and I'll run through a few websites with during this period of next 30 minutes, and also tell you what kind of resources you can use to actually prepare for this exam and to pass this exam. So today's topic, as it says, how to prepare ultrasound certification exam. So there are two examinations currently that are basically kind of well known. One is a certified interventional pain sonology exam from World Institute of Pain, and the other exam is from ASRA, American Society of Regional Anesthesia, Pain Medicine Ultrasound Certificate. It's called PMUC. So those are the two exams. The structures of the exams are very much similar. The material that you can use for both the exam is very similar. The pattern of the exam is very similar. So we will talk about that more in detail. So this is me. I work in Cleveland Clinic in Abu Dhabi. I'm a consultant in pain physician there. I started working there last year. Before that, I was working in the UK in Leicester, and that's where the Leicester Pain Education was born. So what are the events taking place in 2023? So we have a fantastic event lined up on the platform of World Institute of Pain, which is in April 14th and 15th. It's in Orlando, Florida. And there is a FIPP exam and CIPS exam also taking place in Orlando, in Florida on 16th of April. We have a fantastic event lined up in Leicester, my hometown, which is the International Conference on Ultrasound in Pain Medicine. And you've got best of everything in this conference. We've got Professor Bernard Murgel, and I'm going to run through a few nice videos that he's worked on with me on the manual that we prepared for the exam. So Prof. Murgel is a well-known leading world authority in the field of ultrasound in pain management. So this event is in Leicester on 10th and 11th of June. It has 10 CPD CME points recognized from Royal College of Anesthetists. And the event has everything. The event has ultrasound scanning. It has regenerative medicine. It has peripheral neuromodulation. It has central neuromodulation. We're covering cryotherapy. We're covering radio frequency. So every single aspect of pain medicine that you can think of, all the applications that you can think of, is going to be talked over a period of 2 days. We have 2 intensive days. We have workshops of ultrasound. So we have really jam-packed 2 days, and Prof. Murgel is going to be basically showing how to scan various nerves in the body, and we will have an ultrasound hands-on sessions as well. So if you guys are interested, and if you want to visit Leicester, Leicester is about 1 hour drive or train ride from London, and you can register on bookcpd.com. So highly recommend that. Not that because I'm from Leicester. It is a great conference. We had a fantastic conference last year as well. And this is the 3rd conference because we have had such excellent feedback. So, you know, people from Europe and the UK and various parts of the world do come on this conference. Then we have an event in July, which is 15th and 16th of July. It's a NICERA platform. It's an ultrasound in interventional pain management comprehensive workshop. So this workshop is going to be very much useful for the preparation of the exam. The workshop has all the syllabus that you can think of for the CIPS or ASRA PMUC exam. And not only we just teach you about the blocks, we also tell you about their practical application and what I call it as a block style. We have a block style. Everybody has a block style, and we tell you the best block style. Do you do out of plane or do you do in plane, and what needle to use, and what local anesthetic and what steroids, if you do radio frequency, how long do you do it? All those nitty-gritties, all those top tips, clinical pearls will talk you through during this workshop. So this is the specifically designed course which is taking place in Leuven in Belgium on Nisora's platform. It's on 2nd and 3rd of December. I forgot to, yeah, it's 2023, 2nd and 3rd of December. I'm going to quickly run through this video. It just tells you about what's involved in this workshop. We have 2 days of full hands-on scanning. Okay, we basically give you all the material required. It's a practical hands-on live scanning, as well as we have ultrasound simulators. We have small group to faculty ratio, like faculty to delegate ratio. And we also give you the online material if you register for this workshop, and it's on Nisora's website. The registration is open. So what you need to do is just go on the www.nisora.com and go into the events, and you will find the course in December and also the course in July if you are interested to register. Now, what is the structure of the course? The course in December, it's a truly international course. We have all the faculties who are CIPS examiners or CIPS past trainers. We don't have any non-CIPS trainers. So all of them have done the exam. They know how to do the procedures. They know what to expect, how to pass the exam. They know what are the standards of the exam. So day one is all lecture demo. We show you how the procedures are performed on a live model. And then on day two, full day, you start at 8 o'clock in the morning and you keep scanning till 6 o'clock in the evening on various structures. Okay, so when are the next examinations for CIPS? The one is taking place in Florida, as I said, on 16th of April, and the another one is taking place in Turkey. It's on 30th of October. So the reason I just put these dates, because these are the current dates on the World Institute of Pain exam website. When we covered this course, we have about 30 plus ultrasound guided interventional pain procedures. I would say 30 plus. Why is that many procedures? Because there are that many procedures that do get asked in the exams. As I said, we have the CIPS faculty. Now this year we have Dr. Yahya Kamal, who is from Canada, and Dr. Rahul Bansali, who's from the UK. These both are CIPS certified trainers who will be basically joining me in December. The CIPS examination top tips we give you, and throughout the presentations, the exam topics, we highlight them in red. So you basically get very much focused studying. And not only it's only an exam course, it has CME recognition from European Council. So you get 13 CME points. What are the objectives of the exam course? We want to improve your knowledge, improve your scanning skills. And not only you just get better at doing the exam, we want you to be a best needle jockey. So we want to make sure you can perform the block efficiently and accurately and safely. That's why we give you plenty of ultrasound scanning, hands-on scanning day, full day on the second day. The lectures are focused on examination blocks. We tell you about safe practice tips and tricks. Okay, and as I put in a quote there, examination is a game, and you need to know the rules and play the game right to win the game. Okay, so you really need to know what resources to use, how to scan, how to perform the procedure, and that's what you need. Now, at the end of this talk, we will go through some resources, which I'm going to tell you. But what in terms of pain talks, we do have, as I say, we do have a Facebook page. We do have a YouTube page. This is what I'm doing as a part of my voluntary effort to help to spread the knowledge in the world of pain medicine education. I don't get any money for this. I'm just doing entirely voluntarily, putting my own time. So guys, the Facebook and YouTube page is free to access. YouTube channel has previous recordings of all the courses, or not all the courses, all the lectures that we've done. Tomorrow, we have a webinar on introduction to palliative care. So any of you who are interested in cancer pain, put this webinar because it's something that you need to know. What is the role of palliative care when you talk about, you know, a person who's actually at the end of the life, and how can they play an important role making sure that the journey of their life is comfortable, when especially when they are at the stage of dying. And not only just patients who are dying, they do play an important role for symptom management as well. So you will hear that from a very good friend of mine, Neil Nijwan. He works in Burj Hospital in Abu Dhabi. He's actually only qualified palliative care physician in the UAE, the first and only fully qualified physician. He has got dual accreditation. So he's going to be basically talking about this. And then we have a webinar lineup on how to prepare for ADPM and EFIC exam. Okay, so this is Dr. Neil Nijwan. He will be talking to us tomorrow on 5 p.m. UAE time, 1 p.m. UK time, about introduction to palliative care. This is the video of the YouTube channel of Pain Talks, and you could see we have got fantastic webinars. Stan Lamb talked about emerging concepts in pain medicine. So he's talked about ultrasound guided hydrodissection of the nerves using dextrose. We have Prof. Admir Hadzik, who's done a lecture on how to build the teams. We have Georgios Matis talking about history and future of spinal cord stimulation. Then we have vagal nerve stimulation from Peter Statz, major joint neurolysis from Prof. Tony NG. He's currently working in Australia. And then we had Dr. Verma talking about shoulder pain management, Dr. Himanshu Chauhan talking about myofascial pain syndrome, pelvic pain. The fantastic webinar was done by my team here in the UAE, in Cleveland, and they have talked about this. We had psychologists, physiotherapists, and Dr. Jaya Batra, who's a colleague of mine. She has done a fantastic lecture on the pelvic pain. So do access the videos, and the last week's video is also there. And a week before, we had transitional pain service and the role and how to bridge the gap between acute and chronic pain by Professor Hisham Al-Sharkawi, who's from United States. So we have got really, really well-renowned speakers coming on this platform and giving us a fantastic knowledge, all for free, available for you guys to access. So do visit the YouTube channel, do subscribe it. So that's the intro talk. Now, what I'm going to do, without a further delay, I'm just going to dive in to the actual talk of how to prepare for the exam. Okay. So, Amit, are you still there? Can you still hear me?
Yeah, I'm here. I'm very much here.
Fantastic.
And yeah,
I just
so
want
it
to
was
make
a
sure
good
that
introduction.
everybody
Yeah, let's
can
start.
hear it. Okay, so as the talk says, how to prepare for ultrasound certification examination. As I said, there are two exams. One is a CIPS exam from World Institute of Pain called Certified Interventional Pain Sonology Exam. And the other one is called ASRA, American Society of Regional Anesthesia, PMUC, Pain Medicine Ultrasound Certification. So there are two exams that are currently well known. They're there. So why do we need the ultrasound certification? What is the need? If you talk about surgeons, you know, the surgeons will do the diagnosis, followed by that, they do the surgical plan, the insides, they either might put a scope in or they will do a skin incision and they'll perform the procedure to deal with the surgical problem. When it comes to us as a pain physician, we do the diagnosis, we, kind of plan the procedure. But if you don't have imaging as a part of your plan, then majority of time you're doing a guesswork. Okay, and I'll give you simple examples. In the past, people used to use anatomical landmark like lateral femoral cutaneous nerve of thigh, for example. People did landmark technique, and there was a lot of guesswork because we know that nerve is one of the most variable nerves in terms of anatomical location to block. And there was a lot of guessing. And if you do this procedure, you always had no clue whether you're going to have a good outcome or a bad outcome. Okay, so that's where we were. Okay, and when the plan is to avoid guessing. Okay, you really want to take the guessing out. You need to have a full confidence in your interventional pain procedure to tell the patient that, technically I've gone nearer to the nerve, I've deposited the local anesthetic and steroid with 100% confidence. Okay, so you want to avoid the guessing, and that's where the importance of imaging came into play. And this is John J. Bonica in 1953. Okay, he actually recommended use of imaging in his book, okay, Figures of Fluoroscopy, in 1953. In spite of he recommending and putting the images, it took almost half a century for the imaging to become a standard of care. Okay, so, and there are still various parts of the world where the physicians, because they are not trained to use ultrasound, they will carry on either doing the procedure of fluoroscopy guided, which is good, something is better than nothing, but they will probably do an anatomical landmark technique guided injection, where you're doing a lot of guesswork. For example, injecting a knee joint. A lot of orthopedic surgeons, no disrespect to them, they do a great job. But when you are injecting things like platelet-rich plasma or any active substance, you really need to make sure your needle is in the joint space. There is no need to do any guessing. If you use ultrasound, you can be 100% accurate that you are in the joint. And that's why we need the certification for the ultrasound in pain medicine. So ultrasound in pain medicine is not a new topic. It has been used for diagnosis. It was used in 1980s for celiac plexus. Then in early 2000, when there was a lot of implementation of ultrasound in regional anesthesia, the people started to use it for pain management as well. So that's how the ultrasound resurgence in the pain medicine field came up. Okay, so for the past decade, ultrasound in pain medicine made a significant progress in clinical application, education, and research. And if you look at the PubMed, you will find so many papers now on ultrasound in pain management. Okay, so huge amount of progress that we made. And I'm going to leave this slide on for people to actually look at it and read it, okay, because this is very, very important to kind of, to read this through. Okay, so I think, as it says, what was the purpose of certification of the exam? Is to establish the knowledge and skills in the domain of pain practice for certification, to assess knowledge, application of ultrasound-guided interventional techniques of pain medicine physicians in psychometrically valid manner. Okay, so this is something that's very important. To encourage professional growth in the practice of interventional techniques, to formally recognize individuals who meet the requirements set forth by WIP Board of Examination, and to serve public by encouraging quality patient care. And this is, I think, one of the most important bit that I find when you talk about certification for the exam. When I studied for the exam, musculoskeletal ultrasound was my weakest link. I didn't have that much of knowledge about musculoskeletal ultrasound, but the exam made me read about the topic. The exam made me scan many joints, shoulders, rotator cuff, knee joint, hip joint, to diagnose and also to do the intervention. So I think it's very important that you actually provide a good standard of care to your patient. And this is a very good bulletin. Every year it gets published. So have a look on the World Institute of Pain FIPP-CIPS examination website. It tells you about what is involved. Now, exam. What is actual exam? The exam has two parts. The part one is a theoretical part, which has 104 option multiple choice question. And then you have 2 hours to do these MCQs. Now, there are various MCQ books out there to prepare for the pain exam. But when it comes to the ultrasound certification exam, you want to use the books which has more kind of focus on anatomy, ultrasound images. So the book I recommend would be from Dr. Harman Sembi and Dr. Ushma Shah. They were fellows with me in Toronto, regional anesthetist. Herman also did 6 months of fellowship in Toronto in pain management, and they've got a fantastic book on MCQs in regional anesthesia and pain medicine. So it's a very good book, had lots and lots of anatomy, lots and lots of ultrasound pictures, and also, ultrasound basics, pharmacology. These are the topics that you get kind of assessed on. So pharmacology, ultrasound basics, ultrasound imaging. So you basically, that's a very good book that you would go with. So practical part. Now, practical part has two sections. Okay, part 2A is where each examinee is required to perform 4 procedures on cadavers. You have 1 hour to perform 4 procedures, so that's 15 minutes each. Okay, you have 2 examiners assessing you, and then you need to perform the procedure from one region, and I'll give you more details about that. But then what you do, you can start the way you like. If you want to, if you have an MSK procedure which you find easy, you can start with that. Once you put the needle on the cadaver, then the examiners will ask you, is this your final position? And then once you say final position, the examiner will hit the freeze button and the image gets saved. So that's how you basically perform the practical first part of the practice, practical part of the cadaveric needling. Okay, so this is very, very important kind of aspect that you need to keep in mind. Because the problem is, once you have said it's my final position, then unfortunately you cannot change. So it's very important that you take your time, scan the area slowly, take your time to put the needle. If you're struggling to see the needle, make sure you toggle your probe, see where the tip of the needle is lying. And once you are 100% sure and happy with the image, then you tell the examiner that I'm happy with this image. Can you freeze the image? And this is my final position of the needle. So this is what the examiners would expect from you. Now, when we talk about the procedures, these are the procedures. I say the regions. The spine has cervical medial branch, cervical selective nerve root, thoracic facets, lumbar facet, and caudal epidural. 5 procedures from the spine. When it comes to peripheral nerves, you have suprascapular nerve, ileoinguinal iliopagastric nerve, pudendal nerve, ulnar nerve on the cubital tunnel, and lateral femorocutaneous nerve thigh. So you got 5 plus 5, 10. Now MSK, this is where I thought, I needed to put a lot of efforts, which I did. And I do many MSK procedures, including PRP injections, hydrodissections, as well as joint innovations. And I also use hyaluronic acid injections. So acromioclavicular joint, glenohumeral joint, hip joint, knee joint, tibiotalar joint. So these are all the procedures for the MSK. When it comes to soft tissues, you have bicep tendon, subacromial subdeltoid bursa, medial and lateral epicondyle, piriformis, and trochanter bursa. So look, there are already 25 procedures that you would probably will be assessed on. And then part 2. The part 2 is where you have oral examination. So what here they do, there will be 2 examiners. They will give you 1 clinical vignette or 1 clinical case, and there will be a model. So you will have to perform the examination followed by either an ultrasound examination or ultrasound guided procedure. I'll give you a simple example. Somebody with shoulder injury, now unable to move the shoulder. So you will have to perform shoulder joint examination on that model. You'll have to tell the examiners what's your differential diagnosis. Then you will have to tell the examiner that, okay, how are you going to scan the rotator cuff and what's going to be the treatment. So it's very, very kind of like what you would do in your practice with your patient. The examination is very much simulating a practical scenario where you have to put your ultrasound skills to the test. So there are various scenarios on that. So it gives you 30 minutes to spend on a case. Okay, so 30 minutes to spend. As it says, each examinee is individually questioned by 2 examiners on an extended medical vignette, assessing clinical reasoning, knowledge of anatomy, handling of equipment, and physical examination. Now, it is very important, clinical reasoning. So when it comes to like shoulder joint injury, you're gonna tell them what is your differential diagnosis, like a labral tear, or you can say, it could be a rotator cuff tear, it could be an avulsion of the acromioclavicular joint. I'm just giving you an example. You need to then tell them about the anatomy of the knowledge. So if you use ultrasound, you need to show them that, okay, how is the acromioclavicular joint looking like? What's the capsule looking like? How's the rotator cuff looking like? Handling of equipment. So this is very, very, very important. You need to use an appropriate probe. If you're scanning shoulder, don't pick up a curvilinear probe unless the patient's BMI is very high, which is very, very unlikely you'll get in the exam. but it's very important to use set proper depth, set proper gain, show them that you've selected the preset like MSK preset. It's very important. Handling of equipment and physical examination. So pay attention when you're doing the physical exam. Treat that model as a real patient. Have your all kind of clinical manners that you do. Good bedside manner. Introducing the patient, and if the patient says, "Oh, it's hurting," you say, "Okay, I'm very sorry. Apologize." Examine gently. Don't just examine like it's just a model. It's going to be normal. So do exactly what you would do in your clinical practice, and that's what my tip would be. So MCQ exam, I told you, it's something that you will be assessed on pharmacology, ultrasound basics, ultrasound images, clinical scenarios. All those things are going to be so MCQ is all knowledge part. Okay, it's only going to be factual exam information that they will ask you 100 MCQs. Followed by that, then you have the oral part, which is a clinical vignette, where you will basically have two examiners. They will give you a clinical scenario. You have to do the examination, followed by ultrasound examination or a procedure. And then you have cadaveric part, where you have to do 4 cadaveric procedure, 15 minutes each. Okay, so I hope I'm making you guys aware of the whole structure of the exam. I'm trying to paint the picture. Now, basic principles of the exam. Okay, the examiners are there to help you. Okay, we do get good instructions given that please make sure the examinees are put to the ease. Make sure they're comfortable. If they're nervous, offer them the water, offer them a kind of reassurance that, don't worry, take your time, it's no rush, you can do it. We do actually have that kind of approach to the examinees. We don't want you to fail because you're like colleagues. We want to make sure you pass the exam unless you do major mistake. Okay, and we'll talk about that in a minute, but that's what overall structure of the exam is, where you have examiners helping you or supporting you to pass the exam. Okay, now this is the content of the oral exam, and these are the scenarios. So peripheral nerve injury, cervical radicular pain, cervical facet joint pain, occipital neuralgia, shoulder pain, thoracic pain, lumbosacral radicular pain, lumbar facet pain. Now you say, okay, what's this have to do? You will examine the patient, and then you say, okay, I've got a lumbar facet joint problem. So then they'll say, okay, use the ultrasound and show me how you're going to look for the lumbar facet joint and how would you perform lumbar facet joint injection. So I'm just giving you an example. Sacroiliac joint, how would you inject sacroiliac joint with the ultrasound? And similar to that, you have knee pain, hip pain, carpal tunnel syndrome, meralgia parasitica, foot pain, musculoskeletal pain, and disability. So you would have all these clinical scenarios that you will get questioned on. One of those clinical scenarios, one scenario, 2 examiners, 30 minutes. So that's what you do get when you do the exam. Now, few exam tips. When it comes to the cadaver procedure, please keep calm. I know it's exam, everybody gets nervous. I was nervous as well, but obviously, you need to learn how to calm your nerves. So you just have to take a big breath. You have to just kind of calm yourself down. Examiners, as I said, are very helpful. Choose any procedure, any order. If you think you can do knee injection very quickly, and if you do it day in, day out, then choose that. If you are not comfortable with cervical facet, keep that at last, because your knee injection will be done in 5 minutes, and then you can spend more time on the cervical facets. So that's where I would say choose the comfortable procedures first, finish them. That boosts your confidence, that will put you at ease that, okay, I've done all the procedures that I'm very well familiar with, and now I can focus, and I've got plenty of time to do this procedure, which is complex for me. Okay, so it's very important. Cadaveric positioning, you can ask the examiners to get the technicians to help you to position the cadaver. So for example, if you have a cadaver who basically you do have a cadaver for shoulder joint injection, but the cadaver is positioned supine, unless you decide to do an anterior approach to the shoulder joint injection, you can tell the examiners that I want the cadaver to be laid on the prone position so I can do the shoulder joint injection in the prone position. So whatever the position you want the cadaver to be positioned, you can ask for the examiners to do that. Okay, choose your equipment right. Very important when it comes to choosing the needles. Choose a right needle. Okay, for example, if you're doing a suprascapular nerve block, you don't want to choose 15 centimeter needle. You don't need 15 centimeter needle. Okay, you choose the right kind of needle. it's very important. Choose a right probe, you know, curvilinear or linear probe based on what's the cadaver's habitus, body habitus, and what do you do in your practice. You know, I use linear probe all the time for knee joint injection. Now, that's what I will pick up in the patient in the cadaver exam as well. Okay. No need to verbalize, there's no score for that, but it helps you to organize your thought. What I mean verbalization is like running commentary. You can say, okay, I'm going to do knee joint injection. For this, I usually put a pillow under the knee. I make sure that the patient's knees bend. This helps to pull the fluid in the suprapatellar recess. And I'm going to use a high frequency linear ultrasound probe. You know what I mean? I'm just giving you an example that you can run through this commentary, which helps you to organize your thoughts, helps you to pick the right kind of the equipment, and helps you to tell, okay, are you using an in-plane technique or out-of-plane technique? And once your needle is in spot in the right position, final position, you say, okay, this is my final position, and then they will hit the freeze button and they'll save the images. So this is how overall the cadaveric part of the procedure, part of the exam will run through. Okay, so this is what my kind of general tips for the exam. Now, when it comes to the oral exam, as I said, they'll give you a clinical scenario, they'll give you a piece of paper. You will get about 5 minutes to prepare for the clinical scenario. So organize your thoughts. You know, if somebody gives you a clinical scenario of hip joint pain, you need to know, okay, what are the differential diagnoses for hip pain? Is the pain anterior? Is the pain lateral? What questions would you ask? And and when you're actually examining, as I said, when you're examining the model, treat them as a real life patient. Be courteous, be gentle. Always mention biopsychosocial model. Don't straight jump for the injection. Okay, always tell them, I'm going to try and help this patient using a biopsychosocial model of pain management, and they'll just, okay, what medications you're going to use. And they'll also ask you, okay, now tell us what intervention you're planning to do. If say hip joint intra-articular injection, then they'll say, okay, can you explain and can you show me how would you perform intra-articular injection? So that's the oral part of the exam, where you will have an opportunity to use the ultrasound probe, scan the patient, and show them how would you perform that in your real life. Okay, so do what you do in your clinical practice. Don't do anything different. Do what you do in your clinical practice, and that's how you would pass this exam easily. So these are the examinations that they would ask you in the exam: shoulder joint, hip joint, knee joint, lumbar spine, cervical spine, a neurological examination of upper and lower extremity. Okay, so all these examinations are important and you need to learn them, and this is what they will ask you. So this, just recapping the thing, we will be covering a lot of ultrasound guided procedures which are going to be asked in the exam on this conference, which is taking place on 10th and 11th of June. The registrations is live on bookcpd.com. So if you want to visit United Kingdom, Leicester, Leicester is called curry capital of the UK, by the way. You get fantastic curry. So, and then we have another course after June in July, that's in Leuven in Belgium. Is also have lots of procedures that you get asked in the exam. And I said 30 plus procedure. You saw about 20 procedures that basically is a part of the exam, but we have more than that, and we'll cover a lot of procedures. And then we have CIPS review examination course, which can be very helpful to pass ASRA PMUC exam as well. This is on 2nd and 3rd of December in Leuven in Belgium. Okay, so thank you very much. So what I'm going to do is basically show you more resources. What resources can you use for the exam? So let's go through quick resources. The first resource, as I said, is going to be this. So this is the website that we worked on called blockit.club, Painflix. So you heard of Netflix. We have Painflix, a fantastic resource where we have Pain and MSK Sonology video manual. This is a manual for these two exams. There are more than 50 videos in various syllabus as per the exam, which is available for access. You go on the blockit.club website and you can basically click on this, and then you will be able to find more details. And I'm going to quickly play two videos which basically are scanned by me. I'm giving the clinical aspect, and then we have Prof. Bernard Morrigal, and I'm going to play this video. Amit, can you see the video?
Yes, I can see the video.
So I'm going to quickly play this video. This is just demonstrating you, and this is the quality of videos that you have on that website. So I'm just going to show you the greater occipital nerve scanning that Prof. Moragal has done. Okay.
Tricks to get quick to your target. When we look at the proband, I do it on the left-hand side to show you what I do on the right, then by screening, avoiding hiding the picture with my hand and my probe. Again, one important thing is palpation of the mastoid process, okay? And in most instances, you can also palpate a little bit deeper palpation, the C2 spinous process. But even if we can't do that, the orientation, and a quick orientation, is to palpate the tip of the mastoid process, go at approximately 1 finger breadth quarter to it, and this is where your lateral end of your transducer points to. That means then you get an oblique line between the former and the latter. The former is mastoid process and the latter is spinous process. If we turn her head to the other side, and now I will do the same on this side, palpating tip of mastoid process, and then, as I see, 1 finger breadth approximately. In some people, slimmer people, it's only little finger breadths where you point your lateral end of the transducer in a slight obliquely way. And by doing that, I use gel now, you get immediately to the greater occipital nerve. And as the name says, it is really a big one. That means as soon as you put your probe in the position I showed you, you will see a very, very beautiful image. And now look at the position of the transducer, slightly oblique. In your screen, on the right-hand side, and left-hand side. Right-hand side is lateral, left-hand side is medial. And now I just point you out a few things before we go to the nerve itself. As this is medial, you see a little bump, and that's because I scan on the right-hand side of her body, of her neck. This is the right tubercle of the bifid C2. And this huge dark muscle is the obliquus capitis inferior muscle. It is the strongest of those short muscles in the neck that are responsible for rotating movements, etc., etc. And as you see, very much in contrast to this layer, it is almost black. It's so hypoechoic, very typical appearance. And this mixed stuff here is semispinatus capitis. Here's splenius. This is because it is lateral. This is trapezius, and this is this is trapezius, and lateral is sternocleidomastoid muscle. And now we concentrate on the surface of obliquus capitis inferior muscle. And in her case, it's so clear and beautiful. Just by doing one shot in a few seconds, you see the greater occipital nerve. Importantly, you see other structures right in the vicinity being rather black. That might be vessels, especially veins. And by doing compression or less compression, you will see, okay, that's vein or that's nerve. And don't inject into veins. So you be sure and do aspiration before you do your injection. And then, important, whenever you see something that is close to the spinous process in this area, I will show that in detail in a few seconds. As close as this, there's never ever the greater occipital nerve. It has to be in a distance on top of obliquus capitis inferior. Because I didn't use virtual sector so far, you cannot see the lateral end of it. And the lateral end of it will be the transverse process of C1. So I would suggest, especially if you have the possibility, use that tool. If you get that, you see I move my transducer laterally, and now I lose left-hand side of the image, I lose spinous process, but I clearly get transverse process of atlas. There's a big hole down there, beautifully seen in her case. And this big hole down there is the vertebral artery. We will try to do that with color also afterwards. But importantly, because practically speaking, you would come with your needle in plane from medial to lateral. And a lot of people say, okay, it might be dangerous to go to the vertebral artery, but have a look at the distance. So if you do it right, you cannot do any harm to the patient if you put the right setting and the right scanning level. But a clear surface landmark is transverse process of atlas, as I said. And there's another beautiful thing here. You see that hypoechoic, it's almost like a ball. And it's another nervous structure. It's the second dorsal root ganglion and the occipital nerve. And now we try to do that in another image setting. That means I go up again, and now I put my button for virtual sector. And now you see a clear advantage of virtual sector. If you have it, use it. You see everything that is necessary. Medial, spinous process, lamina of axis, lateral, transverse process, big, dark, obliquus capitis inferior, big, greater occipital nerve, vertebral artery, and second dorsal root ganglion. And by the way, it is worth, if you have a good machine, looking at the SCM, sternocleidomastoid. See a tiny little spot, and that's our now more posterior, more cranial, lesser occipital nerve. I call it, to make a joke, but it's also a trick from my side, 4-in-1, okay? Because you see lesser occipital, greater occipital, dorsal root ganglion, and what's the fourth? This one, third occipital nerve, okay? It's always more close to the midline. So if you see something like this, third occipital nerve.
Okay, so you just saw this video. These kind of videos are there on that video manual. I think we basically shot this with Prof. Moragul. Was a very, very long day. I can tell you the guy scans like anything. Okay, we had a marathon, started at 8 o'clock in the morning, and we finished scanning at 9 o'clock at night. So 13 hours we were scanning non-stop. Okay, so here you go, a bit more about this website. So you have this. If you're interested in anatomy and sonoanatomy, there's a whole series of anatomy and sonoanatomy course, which is upper limb, you have lower limb, you have thorax, abdomen, and you also have spine. So all of these are there for you guys to access, to purchase. Now, what other resources are there to prepare for the exam? This is a free resource. This is the Leicester Pain Education's YouTube channel. So when you go on YouTube, you just type in Leicester Pain Education, and you will get this kind of, sign, that the logo of Leicester Pain Education. And if you scroll down, these are all the raw videos. These were my fellows who told me, you know what, if you want to shoot these and we'll put them on a YouTube channel so the next fellow can benefit. So there are lots of procedure videos here. Subacromial subdilated bursa, you've got saphenous nerve, you've got PEX block, you've got ratus lumborum block, femoral nerve block. So there's some regional anesthesia videos, as well as you have chronic pain videos, bicep peritendinous sheath injection, you've got suprascapular nerve, skeletal anatomy, and you've got abdominal blocks. So plenty of videos there. These are all available for you to access for free. Okay, so this is the Leicester Pain Education YouTube channel. And then another resource that you have is NYSORA's website. So NYSORA has a pain management section where you have plenty of pain management procedures that have been done nicely. And very soon, myself and Prof. Admir Hadzik will be bringing out a NYSORA manual for pain procedures. Like you have NYSORA manual for nerve block, we're going to bring the NYSORA manual for pain procedures. So there are plenty of resources that are available for you to prepare for the exams. This all came after I did the exam in 2015. So I relied on the Samir Naro's book, which is a very good book. And the Samir Naro's book is basically now converted into the Nisora's Pain app, where you have all these fantastic, phenomenal illustrations with all these still images. So I think it's a very good resource to use. And then I used the MCQ book of Herman Sembi, and then I also used the book from Benelux chapter from Jan van Zunder for clinical aspects. So clinical scenarios, I actually studied from there. So that's it, guys. I think we went through the whole kind of, stuff that I needed to tell you, what resources, what kind of things you can use to do the exam. So let's do the questions now. So
Excellent, Dr. Sadiq, and a really comprehensive overview of the exams and what all is required. Let's go to the questions here. Most of the questions are about the books. So I think Herman Shambi's book you had already talked, and I messaged also the name. I think so. Let's go to the questions one by one. So first question is, can you write the name of the books, please? So I wrote the MCQs in Regional Anesthesia and Pain Therapy by Herman Shambi. I think what's the other book you were mentioning about?
it's the another book is Samir Naro's book.
Samir Naro's, yes, Samir Naro's. Yeah, I can write that.
Class of ultrasound in pain medicine. Okay.
Another book which I would recommend is Pocket Guide to Ultrasound Guided Interventions in Chronic Pain Management.
Yes,
I'll write the name, and it's it's very
Barry
simple.
Barry
Yeah, by
Nichols.
Andre Kroll and multiple other authors.
Very good book.
So that's another very good book to understand the anatomy, and it's very helpful for let's say to know the sono anatomy too.
Yes.
So that was one question. Then it's most of the questions were about books, so which we already answered. Then we have Mr. Thabet. He's asking, will you be dealing with MSK in the workshop in Leicester?
Yes, MSK is a part of. So as I said, all these 30+ procedure, and that's why I said the examination blocks, majority of the blocks we're going to be covering in Leicester on the conference as well. And Prof. Morgul is going to be there. And you saw the way he scans, the guy scanning, the guy's way of explaining is phenomenal. And I think that's why I would highly recommend you guys to basically either access it like the virtual stuff that we have on the website on blockit.club. He's run all the anatomy courses in 4 modules. We have a ultrasound manual, the video manual, and Prof. Morgul's lots of videos are there as well. And we're going to be covering a lot of MSK in Leicester. So definitely. Yes. So that's
all right. That's about the books, MSK. I have a particular question. So, all these, like, especially for the SIPS exam, let's say you go and you find that the cadaver is not good or the sono anatomy is not very, very good. Can you ask them to change the cadaver or change the procedure at that point?
You can, but put it this way, the examiners will help you during that kind of scenario. If the cadaver's quality is not good, first thing, they will not put that kind of cadaver. If they do, they will expect you to just explain the structures. There might be, put it this way, we in our clinical lives, we don't scan the patients beforehand. Okay, so we don't see book picture in real life as well. You will have patients with a high BMI, or patients have previous surgery, the anatomy may be disturbed. So you will still have to use the known to find the unknown. For example, if it's a lateral thigh, you would look for a well-known structure like anterior superior iliac spine. You will then look for the sartorius muscle. You look for the tensor fascia lata, and then you will try and find your lateral femoral-cutaneous nerve. So you'll have to explain and if you explain these things to the examiners, then they will know, okay, this guy knows his stuff. This guy knows the anatomy for the lateral femoral-cutaneous nerve, and then they will help you. Yes, you can ask to change the cadaver, but sometime if it's not possible, they will help you, and you can just talk through the procedure and you can show them on the ultrasound, and that should be good enough. See, exam is there to assess your competency, to assess your safety, because if, for example, if you're doing cervical facets, now there are 2 wavy lines that you can see when you're doing a cervical facet joint injection. One first wavy line is when you're looking for the vertebral bodies in the cervical region, which also looks like a wavy line. And the second line is the actual cervical facet column. If you stick a needle in the line where you're seeing the cervical vertebral bodies, that's basically a dangerous procedure. You're doing a discogram, which is not what you are intended to do or asked to do. Okay, so that's a straight fail. That procedure is fail. So always make sure you scan anteriorly, and that's what I tell people: scan anteriorly, look for that first line, which is the cervical vertebral bodies with the discs, and then move posteriorly. So now you've showed the examiners that I've scanned the danger structure, and now I'm moving to the structure which I'm supposed to be injecting, or which I've been asked to inject. And that will help you to pass the exam because you've showed them what's dangerous and what you're doing safely. Okay?
That's correct. That's correct.
So that's what I would do. What
All
other?
right. So we have a new question here. Please mention the name of Van Zunder's book. Do you remember the name of the
It's
book?
called as evidence-based pain management. Okay. So, and Van, it's actually Jan Van Zunder.
Yeah, it's Giant Van. Yeah, it's called.
It's a very well-known book. They use it for FIPP exam. It's called evidence-based pain management. Okay, so that's the book that you would use for the exam.
All right, that's correct. So I think that's all for the questions. And thank you, Sadiq, for giving me opportunity to moderate this session. And I'm pretty sure everybody benefited from this.
Thank you. I hope
no more questions. Yes.
So as I said, if you guys want to join us in Leicester in June, you can join us go join me in July in Leuven in Belgium. It's a very, very beautiful place to visit, especially June, July is the summertime in the UK and in Europe, and it's a fantastic weather. So do join me in June, July, or December. Leuven is fantastic because it's Christmas time. And we have a CIPS preparatory course lined up on 2nd and 3rd of December. So you can join me in December as well. Okay, thank you so much, guys. And I will try and put these video recordings on the Pain Talks Facebook page and also on the YouTube channel. So hopefully you will find it useful, and it will be a good recap for you before the exam. If you're doing the exam, look through the webinar, and it will help you to know, okay, what resources to read, what resources to follow. So just to summarize, MCQ book we told about. Amit has written the name in chat box. The evidence-based book from Jan Van Zunder, and for Atlas of Ultrasound Guided Procedures by Samer Naruz. You have a video manual on the blockit.club website from Prof. Moragal, myself, and Dr. Yahya Kamal. And then you have Nysora app for pain and Nysora's website. And then you have Leicester Pain Education, a YouTube channel, which is a free access YouTube channel with all the procedures. And that's what I would use for the exam. So thank you very much, guys. If anybody has any questions, then you can drop an email to the paintalkseducation@gmail.com. That's the email address for Pain Talks. So, and we will see you tomorrow at 5 o'clock on a fantastic webinar on palliative care. So Introduction to Palliative Care by Dr. Neil Nijwan, who is a consultant in palliative care medicine here at Burj Al Hospital in Abu Dhabi. Thank you so much, and have a good evening. Amit, thank you for moderating the session. And thank you, Sadiq. Have a
Everybody take care.
Fantastic evening. Take care. Bye-bye now. Bye.
Bye.